Hello, this lecture is going to be about nursing care of patients with hypertension and peripheral vascular disease. The definition of hypertension has really changed in recent years. And so the American Heart Association came up with new categories of hypertension. And first of all people should have a systolic blood pressure less than 120 and a diastolic less than 80. As you age, it's going to be harder to do this, even if you exercise, eat right, and do all the things you're supposed to do. Okay. So an elevated blood pressure is 120 to 130 and systolic and a diastolic less than 80. Previously, we would call anybody um, under 140 over 90 as pre-hypertension, and we stopped using that term, I think, because as soon as you hear the word pre-hypertension, doesn't mean you have to do anything just yet, right? But you do, okay? Because the goal is always systolic less than 120 and diastolic less than 80. Stage 1 hypertension is a blood pressure 130 to 139 systolically and diastolic 80 to 89. Stage 2 includes a systolic greater than 140 and a diastolic equal to or greater than 90. And sorry, the systolic is also equal or greater than 140. And then hypertension crisis is a blood pressure greater than 180 and a diastolic equal to or greater than 120. When you're looking at blood pressure between systolic and diastolic, I'm like really concerned with the diastolic being high because diastole is the time that the coronary arteries fill with blood. So if your blood pressure, your diastolic blood pressure is really high, that shortens the time the heart is in diastole and shortens the time that the coronary arteries can fill, and your patient can have an MI, okay, because of that. So I always worry about a high diastolic. I mean, I worry about everything, but that's like a medical emergency to have a diastolic greater than 120. Okay, hypertension, the complications, why we need to treat hypertension aggressively is because it can lead to end organ damage. Now, I've talked about heart failure before. That's why patients need to get on blood pressure medication early if lifestyle changes don't help. Okay, but hypertension can end up with renal failure. It can end up with peripheral vascular disease. They can end up with retinopathy. So after 40, you probably learn that you're supposed to get your eyes checked. And that's one of the things the optometrist will be looking at to see if you've developed retinopathy. And it can also lead to hemorrhage or stroke, hemorrhagic stroke, okay? So people with hypertension usually die from long-term damage to their organs. Now, when we talk about hypertension, there's something called modifiable risk factors. And what that means is this is something you can control. This is something we can change. It's not going to be easy, but we can do it. For example, you may need to stop drinking alcohol. You may need to take that salt shaker off the table. Okay? You may need to learn how to de-stress your life. People need to quit smoking. Okay? And if they're diabetics, they need to get tight glycemic control. And students sometimes get confused why diabetes is modifiable, okay? Especially like type 2 diabetes. Oftentimes, if somebody can lose enough weight and take care of themselves, the diabetes can be kept at bay. They need to decrease high cholesterol food intake and, control their blood pressure. All right, some of the things you can't change include your age. So these would be non-modifiable risk factors. Your ethnicity, okay, your gender. I mean, that's kind of questionable nowadays, but for the most part, you really can't, for this sake of this lecture, you can't change your gender. And family history. All right, the chief signs and symptoms. I'm going to be honest with you. Usually there's no signs and symptoms. But if patients are going to have signs and symptoms, they may present with a change in vision. They may complain of blurry vision. They may get a headache if they have really high blood pressure. They may be irritable. They may have epistaxis, which is a nosebleed, which I talked about in the respiratory lecture. And they may suffer from forgetfulness and fatigue. All right, so you have a job with somebody that has mild hypertension. You need to do some patient teaching. You're going to see a theme with all these cardiac diseases, okay? Everybody needs to lose weight. Everybody, well, not everybody, but if you're overweight, you need to lose weight, right? You're going to encourage patients to lose weight. People need to stop smoking. They need to decrease or eliminate alcohol. Exercise 30 to 40 minutes a day if it's safe to do so, right? Because remember, I talked about people with heart failure and coronary artery disease. They may have to do a graduated program, but the goal is to get to 30 to 40 minutes a day. You got to control stress in your life. I know you're in nursing school. I'm in nursing school too. I mean, I cry on the regular. It helps me to relieve stress when I get an assignment that I feel like is impossible. Okay. Patients can go on the DASH diet, which is a diet aimed at stopping hypertension, and it incorporates low fat, low sodium, and low fat dairy products. Okay. Sodium, the diet is a less than 24 milligrams a day, and you might see this in the chart as less than 2 grams of sodium a day. That's typically the way it's prescribed. All right, now the treatment. If your patient has done all those things we just talked about in patient teaching, right? And they're on it. They're doing a great job with that. But the hypertension persists, now it's time for medication, okay? So a physician will do like a graduated approach. It's a step approach. So they'll start with the diuretic, see if that works. If that doesn't work, an antihypertensive is prescribed. Oftentimes, people are put on ACE inhibitors early to prevent renal disease because they lower the blood pressure, but they also decrease the amount of protein loss in the urine. Okay, and protein that when the protein gets filters out, it can damage the kidneys. Let me just say it easily like that. Okay, and then other medications will follow. They may need to use a combination of medications. And then if they're put on the potassium sparing diuretic, okay, the patient is taught to decrease potassium in the diet. Also, this is important if they're put on an ACE inhibitor. They have to watch the potassium in the diet because ACE inhibitors can increase potassium in the body, okay? And then the other thing with ACE inhibitors, explain to them not to use substitute salt, okay, because that is high in potassium. When it comes to antihypertensive medications, there are some things that we need to teach patients to keep them safe. And I know this is kind of broad, but most antihypertension agents are going to lower the blood pressure. So that means the patient is at risk for orthostatic hypotension, especially the older you get, the less your body is responsive to changes in position. So you're going to tell your patient to rise slowly, change position slowly. Don't eat a big meal and get up, okay? Because all the blood is going to be diverted to their gut and they're going to get dizzy. When they first start taking antihypertension medications, they need to be careful driving. They shouldn't drive until they know the effect the medication is going to have on them. And be careful climbing stairs as well because we don't want them to topple down and get a head injury on top of hypertension. All right, foods high in sodium, all the things that taste really good, right? Like pizza, it's so yummy, but high in sodium. Soups, either canned or bagged, yeah, really high in sodium, but totally delicious. So I understand how it's hard to stop this. So you have to be sympathetic and empathetic with and patient with people, and try to really get them to stop eating these foods. Pickles, love them. Soy sauce, oh, so good, and gravy. Okay, Thanksgiving is coming up soon. All right, but you have to, instruct them on a low sodium diet. All right, now some of the complications I've talked about, and I'll probably say it one more time, but I want to talk about malignant hypertension. This typically happens, the most common type of patient is a young male, usually it would be somebody that has stopped taking their medication. So think of the people that are more prone to hypertension. So African Americans, right? They're more prone to hypertension. So they may be more at risk for this. But typically what happens is if a patient is on a beta blocker, especially males, right? It can make them impotent. So they just stop taking the medication without telling anyone. Okay, and this is what happens. They get this rebound malignant hypertension. So the blood pressure rises higher than 180 over 120. Okay, so the symptoms are going to have a really bad headache. And then they're put on nitro medication, which also creates another headache. Okay, but better have a headache than, a stroke. And so you can just give acetaminophen for that. They'll have blurred vision. They could start seizing. They could have a stroke and have a change in their LOC. Okay, so it's really important. We do really good teaching, patient teaching with patients that are put on beta blockers, and they need to reach out to their provider if they're having any side effects, okay, that, is going to cause them not to take the medication suddenly. Again, the complications of hypertension are a hemorrhagic stroke, all right, blood vessel damage, kidney failure, MI and heart failure, and blindness from that retinopathy. Potassium containing foods are important for you to know because if your patients are on diuretics that like loop diuretics like furosemide, they're going to lose potassium. If they're on a potassium sparing diuretic, they're going to gain potassium, and ACE inhibitors can also increase the potassium in the body, so they need to avoid high potassium foods. Okay, so this is review for you because I presented this in the potassium lecture, that foods high in potassium include potatoes, bananas, oranges, so citrus, tomatoes, apricot, strawberries. Remember, salt substitute has increased potassium in it, iceberg lettuce, and ugly fruit. Those are high potassium foods. Now, you would recommend the low potassium foods for people possibly that are on ACE inhibitors, potassium sparing diuretics, or have kidney disease, okay? Because if the kidney is not working, the body cannot excrete potassium. Very important for you to know. So like foods that are low in potassium are apples, corn, pineapple, grapes, green beans, carrots, celery. So make sure you know the high potassium foods and the low potassium foods. All right, now we're going to go into peripheral vascular disease, okay, caused by arteriosclerosis and arteriosclerosis. All right, so this is kind of confusing to people. Peripheral vascular disease is abbreviated PVD, but so is peripheral venous disease, okay? I posted a great video for you to watch on the difference between PAD and PVD, because you'll have to kind of distinguish that, okay? So with peripheral artery disease, it involves narrowing of the arteries, all right, or obstruction of the arteries, okay? Now, the reason you have to know the difference is because the signs and symptoms of an arterial disease are different than the venous disease, right? Because an artery carries oxygenated blood. That's a key point. And a vein carries unoxygenated blood, okay? All right. So when we talk about peripheral artery disease, we're talking about all the arteries in the periphery, not the heart and the brain. But oftentimes, if you've got problems in the periphery, you have problems in the heart and the brain as well. Okay, so causes can be, people with diabetes are going to be prone to this. That's why we like people to have tight glycemic control. People with Raynaud's disease, and I'll talk about that later. People with aneurysms. Somebody could have a arterial embolism, okay, and that could occlude a whole artery in the periphery. All right, so it can be acute or chronic. Okay, so acute would be like somebody throws an embolism, okay, and it cuts off blood flow to a limb. And then chronic is like, people that are smokers can get chronic peripheral arterial disease. Okay, so I just want to point something out here. Both peripheral arterial disease and peripheral venous disease are prone to ulcers, but there's an important thing I need to tell you. Okay, look at this ulcer here. You see how the edges are sharp, distinct? That is characteristic of a peripheral arterial disease. All right, so because the arteries carry oxygen, when the patient exercises, they're going to have pain, okay? Because that means the limbs, usually the legs, are not getting enough oxygen, okay? So they're going to have what's called intermittent claudication. That means it hurts when they walk, okay? Because the blood in the legs is not getting to the tissues, and you need that when you exercise. They will have pain at rest. They'll get tightening pressure in their calves or buttocks. Okay, so the most important thing is to know that they're going to have pain at rest and intermittent claudication, but this is also important. They're going to have paleness when the leg is elevated and rubor when the leg is dependent, okay? And rubor means the leg is going to turn red when it's down, okay? All right, and the skin on their legs is going to be tight and shiny and hairless. They'll have thick nails because the nails are not getting oxygen. They're going to have weak distal pulses and the extremity may be cool. This is just a description of the peripheral pulses you'll be feeling, or assessing, I should say, palpating. So the bottom one is the pedal pulse, the first one, then the posterior tib. Those are the two most common ones you would be assessing, like after a cardiac cath, or if your patient had peripheral artery disease or PVD, or after surgery, you want to check, or you're doing neurovascular checks on the lower extremities. Those are the two most common pulses you will be palpating. And you can see the femoral up here. The popliteal is a little bit harder for students. It's in the back of the knee, and it's kind of a deeper artery, so it's harder to palpate, I should say. Okay, now these are the 6 Ps. I think I talked about it after cardiac catheterization. Anytime you do like a procedure that involves the arteries, you need to be checking for the 6 Ps in the limb that they had the procedure in. So like angioplasty or cardiac catheterization, you're going to check for the 6 Ps. So you assess the limb for pain, pulselessness, poikilothermia, which means coldness, okay, pallor, which means pale, paresthesias, which could mean like pins and needles, and paralysis, which means the leg or the limb cannot move, okay? So those are the 6 Ps of neurovascular assessment. And you would do this every 15 minutes when a patient first comes out from a cardiac cath or an angioplasty. But you also do this assessment on anybody that you suspect has vascular disease. All right, so the treatment. Exercise is the best treatment. They need to start walking vigorously for 20 minutes twice a day. They start off slow, right? Work up to 45 to 60 minutes a day and stop smoking. Everybody needs to stop smoking, especially with peripheral artery disease. That's like the #1 cause of peripheral artery disease. And they can't really take nicotine patches because nicotine is a vasoconstrictor, so it can like make it worse. All right, so some of the medications. Aspirin is the most common antiplatelet medication, and they will be placed on aspirin, typically at a dose of 81 milligrams per day. That's like the cardiac dose. They'll be put on cholesterol-lowering medications, and then if that doesn't work, also they may also add to aspirin clopidogrel, which is also an antiplatelet medication. Now, if it's really bad and all these, the exercise isn't working, the medications isn't working, they can go for surgery. And if you look at this picture here and you see the blue veins, okay, this is a bypass, okay? So we call, this kind of surgery, you may have heard of a fempop, okay? So a fempop is the second picture over here. They take the vein and they use it as a graft from the femoral artery down to the popliteal artery, and that's a fempop. And you can see that's a little bit of a longer surgery, or I should say a longer graft than the aortoiliac. Okay, but they're both bypasses. All right, and it's done to get more blood flow to that area, and it's only palliative. Okay, and so when the patient came out of surgery, in addition to everything else you assess after somebody has surgery, you would be doing the 6Ps as part of your assessment. All right, and anybody that has a graft, whether it is you know, a bypass graft from the arteries to the veins, or if it's a bypass in the heart, or anywhere else on the body, there's something you need to know. You need the blood pressure about 140 systolic. Okay, that might be a good result, because if the blood pressure goes too low, the graft will collapse. And if the blood pressure is too high, the graft can blow out, right? It puts pressure on the graft. So we need Goldilocks blood pressure after peripheral artery disease surgery. All right, so this is just in general. Anybody that has peripheral artery disease, you want to keep them warm. They need to avoid being cold, because when you're cold, you have vasoconstriction. Just like I told you with people with coronary artery disease, they need to be warm, because if they get cold and those coronary arteries constrict, they could get unstable angina or angina, right? All right, encourage them to change position frequently, because they need to be walking around. Legs should be positioned at the below the level of the heart for arterial vascular disease, because they're going to get pain if it's not. Okay, so they'll probably just do that anyway. In a way you can remember it, okay, is with arterial disease, you want the legs down. Okay, so look at how when I draw these legs on this little stick figure, you put like an imaginary line across the legs and it looks like an A. Okay, so that's how you remember that legs need to go down in arterial disease. Okay, encourage exercise like walking and swimming, and patients should dress in non-restrictive clothing. Okay, so be careful putting on TED stockings on somebody that has arterial disease. Here's your patient teaching for clients with peripheral vascular disease. All right, you want to tell them to keep their environment warm. They don't want to get cold, because when patients get cold, they vasoconstrict and it's going to cut off their circulation more. Bath water should be set to 120 degrees Fahrenheit. In other words, it can't go higher than that. People with peripheral vascular disease are not going to be able to feel as well as other people, because they have neuropathy usually, and so they have to also inspect their feet daily, because they may not feel an ulcer coming on. They also should not use heating pads for the same reasons that they won't be able to feel a really hot temperature. They shouldn't walk around in bare feet, because again, they're not going to feel it if they have an abrasion on their bottom of their foot. They shouldn't wear constrictive clothing like I bought these socks online. They were so cute, but they had this thick elastic band at the top. They were knee socks, and it was like cutting off my circulation. Like, they shouldn't wear that kind of constrictive clothing. They should wear socks, but it shouldn't have the tight elastic in them. Instruct them not to cross their legs, and obviously they shouldn't smoke, drink. They should eat a healthy diet, etc. Okay, now I'm going to talk about deep vein thrombus. Now, this should be like a remix for you, right? Because you did this in your post-op lecture, okay? So I have a little mnemonic that tells you who's at risk for DVT, okay? So it's thrombosis. So people that travel, or people that have trauma, like somebody in a motor vehicle accident, I would be very worried they're going to end up with a DVT and possibly a PE, okay? Hospital, people in the hospital, everybody in the hospital needs to be evaluated within 24 hours for the risk of VTE, and VTE stands for venous thromboembolism, okay? Hormones, so people on estrogen and tamoxifen are at high risk. I took care of a girl, 26 years old, on blood pressure medication who developed a clot and had a stroke. Okay, because she was on not blood pressure medication, she was on birth control pills. Sad. Um, Relatives, this is a rare disease. I wouldn't worry about that too much. I did get to take care of somebody with this disease when I was in clinical, and that was kind of exciting. But anybody at old age, they're going to be at risk. People with malignancies, a lot of cancers are thrombogenic. And that's one of the first things I think about if I have a young person that comes into the hospital with a DVT and they don't have a history of anything. I think, oh no, they have hidden cancer. We call that latent cancer somewhere in their body, okay? And typically they get worked up for that. B stands for long bone fracture. That can result in fat emboli, okay? And then obstetrics is for O. So orthopedic surgery, highly thrombogenic. Hip surgery, total hip replacement, has the highest incidence of DVT out of all surgeries, okay? And oncology, again, cancer. A smoker, okay? Anybody that smokes is at risk for DVT. Anybody post-surgical is at risk. Anybody that's immobilized for 4 to 5 days is going to be at risk for DVT. And then there are some sicknesses, but I wouldn't worry about that. You've learned what's really important this semester, okay, about what's going to cause a DVT. Okay. The main sign, you'll see edema and redness in one leg and not the other one. Typically, it's a leg. It can happen in the upper extremities, but typically it's a leg. Super important that you know how to document pitting edema. In a lot of conditions we talked about this semester, you are going to be documenting pitting edema, like in hypernatremia, congestive heart failure, those kind of conditions. Uh, Somebody with venous insufficiency could have pitting edema. So basically, you evaluate the skin by pressing down with your thumb or your finger over a bony prominence, like usually the ankle, the tibia, so like in the lower extremity usually. And the depth of the edema reflects the degree of edema. So if you have grade 0 edema, that means they have no edema. If you have +1, that's trace. Okay, you have to know the severity, trace edema, pitting edema, and it'll be 2 millimeters. And it's a rapid skin response, meaning when I press the edema, it goes to 2 millimeters and it recoils rapidly. When we get to grade 2, okay, it's going to be mild edema, considered mild edema, and there'll be a 4 millimeter indentation, and it's going to take 10 to 15 seconds to recoil back the skin. +3 equals moderate, and the skin will indent to 6 millimeters, and there'll be a prolonged skin response, meaning it'll take longer to recoil back to normal than +2 and +1. And then finally, +4 is severe, and it will indent to 8 millimeters, and so you'll have a prolonged skin response. Now, with all of these, all you have to do with the grade is multiply it by 2, and you will get the amount of millimeters of the indentation. For example, look at grade 1 times 2 equals a 2 millimeter indentation. Grade 2 times 2 equals a 4 millimeter indentation. Grade 3 times 2 equals 6 millimeters of indentation. Grade 4 times 2 equals 8 millimeters of indentation. So that's a little trick that can help you. Treatment for DVT. For a DVT that is large enough, they're going to be started on a heparin drip initially. And warfarin will also be given PO because warfarin is going to take 3 to 5 days to become effective. So that's why they're in the beginning, they're on like a heparin warfarin bridge. If it's a small enough DVT, they may be prescribed enoxaparin, which is given SC. And then to prevent the extension of the clot and further clotting, they will be on anticoagulations for 3 to 6 months if it's their first episode. If it's their second episode, having a DVT, they will be on anticoagulants for 1 year. Okay, now the interventions for DVT are the same as when I talked about with PE. Okay, to prevent PE and DVT, early ambulation after surgery is key. They can have compression socks, or they should have compression stockings or SCDs on. This is called mechanical prophylaxis, but I will tell you that medications are much better. Chemical prophylaxis work is more efficient at preventing DVTs. And a vena cava filter, which is also a Greenfield filter, and I have a picture of here. See, it looks like a little basket, and they put it in the inferior vena cava. They can do it in like special procedures or a vascular lab, and they just, thread it up through and lodge it in the inferior vena cava, and then it can catch clots. All right, now I'm going to go into peripheral venous disease. Okay, so this means there's, venous stasis, or it could be called as venous insufficiency. I want you to look at this stasis ulcer, okay, of the venous. You see how it's not, the edges are not smooth, it's kind of jagged. Okay, so that's indicative of a venous stasis ulcer. That's how you can kind of tell them apart. One other thing I noticed right away, looking at this patient leg, is the brown discoloration, which is also indicative of venous stasis or peripheral venous disease. Okay, now we're going to compare and contrast arterial peripheral vascular disease versus venous peripheral vascular disease, because you're going to have to be able to distinguish by the signs and symptoms if somebody has an arterial problem versus a venous problem. Okay, first we're going to start with pulses. Remember, when you're palpating a pulse, you're palpating the artery, okay? So somebody with arterial disease is going to have a diminished, weak, or absent pulse in their extremity. If you do have an absent pulse, make sure you get a Doppler and check, because you may not be able to feel it, but the Doppler may pick up that there is still some circulation going to that limb. Whereas venous, they'll have a strong and symmetrical pulse. And remember, the amplitude we like to see is +2. Okay, that's a normal amplitude, or I should say strength of a pulse. Okay, so that's what we're trying to look for. And then when it comes to the skin colors, with arterial, their limb is going to be pale. When they put their legs down, they'll have rubor, meaning the legs will fill up, and they'll have it's kind of like a bright red color. And the skin is going to be thin, shiny, with little hair, okay? Whereas with venous peripheral vascular disease, they'll have brown pigmentation at the ankles, okay? And the leg will be warm, whereas the skin on arterial vascular disease, it could be cool. All right, edema in arterial disease is going to be absent. In venous disease, it will be present, okay? And make sure you know how to document pitting edema. Ulceration with arterial, it's going to be at the toes and the pressure points, and it's going to be sharp and painless. Whereas venous is going to have irregular borders, and it's going to probably be at the bones of the ankle. Okay, so that's where you're most likely going to see it. Arterial disease is going to be prone to necrosis and gangrene, and venous disease will not be. The pain in arterial has intermittent claudication, and it lessens at rest, whereas with venous, it's more of an aching, and they'll have nocturnal cramps when they're in bed. Okay, nails in arterial are going to be thick and brittle, but this is also a normal finding in older adults, so it's not really accurate in an older adult. Whereas venous disease has normal nails. And then we talked about the hair. Okay, in arterial, they're going to lose the hair on their legs, whereas in venous disease, it will be normal. Okay, I just wanted to add one more thing. Every time you listen to a lecture or you do a study session, you should really be following it up with NCLEX questions, okay? Or with one of the Quizlets I've made. Like, you should go do one of those Quizlets. Those are a lot of knowledge-based questions, but it will help you remember. But it also points out to you what you didn't learn, okay? oftentimes students study a lot and get really confident that they're going to do well on an exam. But if they're not following up with some type of assessment to assess their learning, it's false, okay? You need to be doing questions every time you have a study session. That's why we make everybody do questions weekly in our program, and we have great success in our program, and I want you to be successful. That's why I provided Quizlets for you. Okay, so I really want to encourage you to go do the Quizlets when you're done studying.